Welcome everybody to our REACH ACO presentation as part of Ropes and Gray's Value-Based Care 2.0. We're excited to have you joining us today for this presentation. A few housekeeping items before we begin. This panel discussion is eligible for CLE credit. We'll read the CLE code during our discussion and we'll post it in our chat. We'll send a link in the chat to the form you have to fill out to enter the CLE code. And we will also send this information via email at the end of the presentation. If you have any questions for our panelists or Sarah and myself, please ask those in the chat and we'll get to them either during the presentation or at the end. With that out of our way, let's get started. My name is Christina Bergeron. I'm a partner in the healthcare group in our Boston office. I've been advising clients on CMMI value-based related models for 7 or 8 years now, with most recent, the ACO REACH model. We help with things like strategy, legal considerations related to provider or beneficiary engagement, and other questions of that nature. I'll turn it over to Sarah for an intro.
Hi, thank you, Christina. My name is Sarah Blumenthal. I practice in the healthcare group at Ropes with Christina. I've been advising clients on accountable care organizations and integrated delivery systems for more than 10 years since the inception of the Medicare Shared Savings Program under the Affordable Care Act. I've continued to advise clients on the specialized models being tested by the Center for Medicare and Medicaid Innovation, CMMI, including the historic Pioneer ACO model, the Next Gen ACO model, along with the current Global and Professional Direct Contracting model, also known as DCE model, which we'll be talking about today. Christina, would you like to give a brief update on the new changes to the DCE model?
Of course. On February 24th of this year, CMMI, the CMS Innovation Center, unveiled the new ACO REACH model. REACH stands for Realizing Equity, Access, and Community Health. This model will replace the December 2022 DCE model. And today we have brought together a panel of experts to discuss the new ACO REACH model in depth, including Andrea Osborne, who serves as the Senior Vice President for ACO Operations for VillageMD, Spencer Caruccio, who serves as the Vice President at Oxyon Ventures, which has investments in various ACO opportunities, and Deepak Kohaliday, President of Advanced Primary Care at Convenient MD, which currently participates in the DCE program. Panelists, welcome to our presentation. It's a privilege and pleasure to have you all here. Before we dive into questions for you all, we'd like you all to share a little bit about your background. Andrea, let's start with you.
Hi, thanks for having me today. So VillageMD is currently participating in 6 direct contracting entities across our nation. Of those, we have all of those as a standard global and are using total care capitation. I get the privilege of helping to manage those along with the team. Prior to this, I actually spent 16 years operating nursing homes, so very familiar with the post-acute sector, and helped nursing homes set up arrangements with the Pioneer ACOs and the MSSP ACOs on how to be a preferred provider and help to introduce some of the post-acute value-based structures for payments with a lot of ACOs.
Awesome, thanks Andrea. Looking forward to talking more about REACH with you. Spencer, do you want to go next?
Absolutely, and great to be here. So my name is Spencer Caruccio, a vice president in Oxyon's venture studio. So we do new company creation all around healthcare companies. One of our newest companies is focused on kind of the serious illness space, in particular working with serious illness providers around the high needs DCE / high needs ACO REACH program, where we see a lot of opportunity for those providers that are caring for those patients in the last 2 to 3 years of life. For my background, I was at CMMI as a senior advisor to the director working on direct contracting as well as some other cross-center initiatives, and have been at a bunch of value-based care companies throughout my career, including Remedy Partners, which was the biggest awardee convener within the Bundled Payments for Care Improvement Program, and CityBlock Health, which is doing advanced primary care for kind of Medicaid and Medicare beneficiaries with higher needs as well. So really excited to be here today.
Thank you, Spencer. Deepak, you could go next.
Yeah, thanks. Thanks for having me here, and great to be on this panel. Really quick, my background: I have spent about 10 plus years at United Healthcare, working on our value-based programs from a payer side, but working very closely with primary care groups across the country in different product lines, commercial, Medicare, Medicaid, and was lately running their ACO book of business nationally for the commercial program, so about 100 plus ACO contracts. So done a bunch of different work in this space around value-based care and practice transformation, primary care transformation, and currently just recently joined ConveneMD in building out our primary care model with value-based care kind of approaches built into it. So happy to be here and look forward to the conversation.
Thank you, Deepak. Excited for all of your insights. Sarah, I'll turn it to you to kick us off with some background on ACO REACH model before we dive into more detail.
Thanks, Christina. So the ACO REACH model is the current administration's redesign of the DCE program. It's set to begin on January 1st, 2023. It will run through the remaining 4 performance years of the DCE program through 2026. The administration's stated key objectives for the ACO REACH model include advancing health equity, supporting innovation, aligning this model with its strategic objectives to migrate increasing numbers of Medicare fee-for-service beneficiaries into accountable care models. There are several key changes in the DCE program. Our panelists will discuss some, but at a high level, they've reduced the benchmark discount from up to 5% to up to 3.5%. They've reduced the quality withhold from 5% to 2%. They've increased the role of participant providers on the governing board, now mirroring many other CMS programs, requiring 75% of the governing board to be composed of participant providers or representatives of participant providers. The Medicare beneficiary and the consumer advocate board members must now be 2 separate individuals, and they must sit on the board with a vote. CMMI has introduced new health equity policies, including a benchmark adjustment and additional benefit enhancements. We'll explore with the panel the legal and operational impact of these changes.
Thanks, perfect, Sarah. And if you are in the current DCE model and you meet model requirements and have a strong compliance record, you can participate in the new model. And for those who applied, we should be hearing by the end of June. I think we thought we'd be hearing earlier, but rumor has it we'll be hearing by the end of June who is approved to participate. I know there was sort of sounds like a record number of applications. CMMI is looking at, among other things, for organizations that do have experience in risk-based models, including experience with treating populations with health inequities. Importantly, there is no restriction on who the organizations, the ACO can be owned by. It could be private equity backed or not. The 75% governing board requirement is separate from an ownership requirement as it relates to participant providers, which is an important point for some of our clients. Okay, with that, let's jump into some of the questions for our panelists. Our first question is understanding how each of you and your organizations are participating in DCE or anticipating to participate in ACO REACH. Spencer, let's start with you.
Great. So our organization is particularly focused on the high needs track of DCE/ACO REACH. Within that, doing focus on PCC as the path, but really, I think as we've thought about our particular differentiating point is around high needs as the area that we think is kind of meeting both our mission as Compassion Health and the best model that fits with kind of the providers that we are assisting.
Awesome. Spencer, would you mind explaining to our audience what the distinction is of a high needs DCE/ACO?
Sure. Yeah. Done this explanation a lot, so happy to. So the high needs ACO REACH is a particular track of the ACO REACH/DCE model focused on beneficiaries with a specific set of eligibility criteria, kind of targeting these beneficiaries that have higher needs. That eligibility criteria kind of is a series of one, some focused on risk score kind of above certain thresholds, depending on if they've got historic hospital admissions or not, a set of diagnosis codes that represent kind of frailty or mobility conditions like cystic fibrosis, or a set of DME criteria like hospital beds or transport DME that are representing kind of patients with mobility problems. So it's recognizing that for a certain subset of the population, right, those that meet kind of this proxy for what is a patient with high needs, that there is kind of a different set of model design criteria that need to exist around that to appropriately reimburse for what is a sicker population that tends to go through kind of quicker changes in their health status, right, for a lot of these patients. One of the major differences from a model design perspective is the different risk adjustment model used within high needs. So it utilizes a concurrent risk adjustment model, the CMMI HCC model, that utilizes the codes from the same year to predict the risk score for that year, right? Recognizing that given this subset of patients, that these patients are more often kind of getting sicker more rapidly throughout the year, and therefore having a risk adjustment algorithm that is tracking against that kind of disease change, that transition of disease, more accurately kind of reimburses and provides that amount of kind of dollars to better manage those patients over that timeline. There are some other differences that kind of get much more into the weeds, but ultimately those, I think, as we've thought about kind of the particular differences, that eligibility criteria and that risk adjustment are the ones that really compose kind of the biggest difference when we look at the comparison to either the new entrant or standard DCE/ACO REACH tracks.
That makes sense. And Spencer, just one follow-up question to that. Can hospice patients qualify as a beneficiary in the high needs DCE, or is it people who are pre-hospice certification?
Yeah, so as you know, hospice is included within all of the different kind of tracks within this, so they can be, right? I think as we think about when patients become eligible, we want to try to get that as farther up as possible, right? As we think about the benefit of, say, of palliative care, right? We think of palliative care as a much broader set of services rather than just hospice. Right, so how do we start bringing palliative care 2 years up before end of life? And there is where we see kind of the potential for high needs to be farther up that chain. But patients kind of throughout that journey can be eligible to enroll. The complexity in there comes with the alignment mechanisms, where claims-based alignment, given a historic look back that with a 6-month lag and then a 2-year look back, patients that are in hospice, right, you would need to manage them for that time frame. And voluntary alignment, which I think we'll discuss a little bit more later, provides a lot of potential to bring patients in that kind of more end-of-life journey. But there are some complexities from a compliance perspective to make sure that that is utilized effectively to get these patients into the right model.
Got it. Makes sense. Looking forward to unpacking that a little bit more in our presentation. Andrea, let's kick it to you next. How is VillageMD participating in REACH?
Yeah, so currently, as I said a little bit earlier, we're currently in 6 direct contracting entities, all are standard global total care capitation. We do plan to roll over to the ACO REACH model and looking forward to that. For us, under the total care capitation, not only are we paying claims to our participant providers, but we've also been diligently working to build our preferred provider group as well, and to pay claims to them and to be able to transform the way that not only we get paid on a quality basis, but that also our other partners downstream are participating with us as partners throughout this program. And currently we're sponsoring about 73,000 Medicare beneficiaries in our DCE programs.
Andrea, thank you so much. Just two follow-ups for you. Would you mind explaining to our panelists the difference between sort of the global versus professional track?
Yeah, so the global track is where you have full upside and downside, 100% upside and downside after CMX, and then CMS, of course, takes their 2% discount. With professional, you have reduced risk, so you're only looking at 50% upside and downside. So if you're not ready to fully jump in at that 100%, it allows you more of a glide path of partial risk before going to full risk.
Got it. Extremely helpful. And one other question, how do you see when you talk about your preferred provider network, how do you see them as sort of critical to obtaining your goals in the program?
Yes, so one of the things we like about this program is it allows the primary care physician to, I was like to say, be the quarterback of care for our patients, to ensure that the right things are happening for patients, but we're only one portion of the care that patient needs. And we want to ensure that every time a patient touches a cardiologist or a hospital or a nursing home, that everyone is operating with the same intentions to coordinate care. And we feel like if we don't bring them along with us, it's going to be impossible to actually improve outcomes for patients unless we try to ensure that all the providers that our patients interact with are part of the same goal.
Yeah, absolutely. Absolutely. That's a major theme, I feel like, with these models. Deepak, how about you? How is Convenient MD currently participating in DCE, and how does it plan to participate in REACH?
So, thank you. So we are in the primary care side only. So the professional capitation model is what we have signed up for as a participating provider in a DCE. And just for the benefit of this audience, our primary care clinics actually start in August. So we are kind of still in the build phase. And our goal is, and our DCE's goal is to kind of roll on to the ACO REACH program, right? So right now we are in the DCE space, but getting ready for ACO REACH as it rolls around in 23. We are one of the applicants. So we're waiting for what happens when the decision is made, but we're optimistic of kind of being there. The other thing we have kind of also done while we are standing up our businesses, we have an urgent care business, which coincidentally, we got some patients attributed through that and gave us a little bit of feel for what's happening on the DCE side. And so we have been engaging in sort of population health and care coordination activities, similar to what Andrea was just describing, getting ready for when we get into the full operations and having more patients sort of flow through our channel. So still early days for us, but we're kind of dipping our toes in the water here.
I think that's really interesting, though, that as the three of you are speaking, it's all very different, right, across the board in sort of, the care coordination and how you're involving the patient with primary care. And I think that was one of CMMI's goals with this model and some of the aspects of it. So thank you so much for that intro. I'll kick it over to Sarah for the next question.
Thanks, Christina. And I think this is a good follow-up, given the different business incentives for each of you in participating in the different paths and tracks you're participating in the ACO REACH program. Our question is, why is your organization participating in the DCE program? What are your goals in continuing to participate in the ACO REACH program? How does this advance your mission and your business justification? Why don't we start with Deepak?
Yeah, sure. Thanks, Sarah. I would say, Convenient MD, we've been around for 10 years as an urgent care chain in the New England area, so Maine, New Hampshire, and Massachusetts. And the business model we have set up on the urgent care side has been about deflecting unnecessary ED utilization and kind of acting as a spillover for primary care when they don't get access. So we have kind of already been in the space of trying to solve access and cost of care and improving quality for our communities. And so getting into advanced primary care was sort of a logical extension for us as a business to continue that mission, right? So it's sort of very well aligned from a mission perspective for us. And there's a huge unmet need, especially in this geography, for primary care. So as we scope the market out, we scope the needs out, it seemed like a perfect fit both from a mission and strategy perspective. And then as far as DCE is concerned, that's something which, as we were building the business plans out, it was kind of very evident that the Medicare space in this geography is not very well served from an accountable care or value-based care perspective. And so that aligned very well as well from a market positioning perspective, that there's a huge need in the Medicare side and sort of a greenfield space for us to build our business around it. So those are kind of the big reasons why we are building our primary care and why we are sort of going into the DCE track here.
Thank you. Agree in terms of how the Medicare program and how the region, can benefit from more alignment and more integration. Spencer, why don't we turn to you next?
Yeah, so I think our main excitement here is kind of twofold. One, I think echoing kind of Christina's point, there's a lot of flexibility in how do you use ACO, REACH, or DC on achieving whatever goals you have, right? And that's the nice part of a total cost of care model and the waivers that are part of it, and capitation and global cap, right, is the ability to really use it to kind of further whatever kind of mission you all have. For us, kind of given our focus on serious illness, a lot of these providers that we are working with, right, we are an enabler, not a provider ourselves, are home-based, community-based providers, right? And these providers under fee-for-service have struggled to come to a business model that has helped them scale, right? It is very hard to run a business on fee-for-service when you have windshield time and driving between patients' homes, right? It is a really hard model to drive kind of efficiency out of, and it's a really hard model to scale. So we are really excited by value-based care generally, right, for home and community-based providers, because it can provide what we think is a much better business model for a care model we really believe in, right? And we've seen examples of that care model within either on the palliative care side, like models like the Medicare Care Choices model, which was a really early kind of community-based palliative care model, Independence at Home as an early example of a model focused on enabling home-based primary care, right? We've seen all of the examples of how value-based care has enabled kind of these types of care models to be much more effective and to really start to scale. And we are excited by ACO REACH because of its ability to kind of be able to replicate versions of those, right? And we can be creative as we think about stepping below the cap, right? How do we want to structure preferred provider arrangements or different provider arrangements to provide kind of replications of different models depending on different local market contexts? Because we recognize that in each market, there is a different set of providers, a different set of needs, a different set of services, and that flexibility and kind of us focusing on being an enabler can help create those networks underneath something like ACO REACH to enable that value-based care model that then enables what we think is this right clinical model to scale.
Yeah, and I would echo the point that the DCE model creates a flexibility for provider groups, for provider organizations, for organizations coming in to design the business that works for them. That there is no set compensation structure for any of the models. And Deepak, I'm curious, as you build into your DCE participation, has that flexibility been a factor in your consideration of the DCEs and of the compensation methodologies that are offered to you as a participating provider?
Yeah, certainly. I think that's certainly a key theme. And I think it's one of the big lessons CMS also learned through the MSSP and Next Gen and Pioneer programs. I think when I was in my United Days, definitely we were kind of giving feedback to CMS that there were a certain amount of constraints in that model which were kind of limiting its potential. And I think to CMS's credit, they listened. And in this version, I think Spencer articulated many of the reasons for many of the factors which give flexibility. That is certainly very key. And you know, for example, think on the beneficiaries benefit design side, we have kind of started designing some new basically bolting on new products to the Medicare benefit plan, right? Which we couldn't do in the previous piece. And I think for value-based care to work, as much as the care delivery system gets an opportunity to do things differently, we also want patients to engage with the system differently. And we could not do that in sort of the original Medicare standard benefit designs. So I think that flexibility is turning out to be very key. And as we have started doing patient outreach for voluntary alignment and get patients on board, and that has become a big, and I would think others have benefited too, is that becomes a big recruiting aspect, right? We can explain to the patient that, hey, this is enhancing the benefits you already receive in addition to the clinical care we can give, right? So I think for value-based care to work, both the providers and the patients have to change. And I think this model gives that flexibility and has been at the core of how we have started designing our model over here.
Yeah, thank you. And I want to talk a bit more about beneficiary engagement in a little bit later in the panel, because I think that's absolutely right. The new way to engage providers and engage beneficiaries. This only works. We're talking about it, right? We lawyers sit up top of our ivory towers and think about the model and how you build it. But really, this only works. And really, this has the capacity to transform how we deliver care because we're changing the way providers and patients engage with each other. Andrea, before we move off this question, if you can talk a little bit about VillageMD's strategy here.
Yeah, so I think Deepak and Spencer said it really well. Our providers are excited for this model. They don't want to provide sick care. They want to provide health care. And this model makes that a possibility. And so doctors are excited and they want to be in this program. They want to be able to provide that comprehensive care and have a business model from CMS that allows them to do it. I think also with the ACO reach for us as a company, we're very public that we are opening 500 new clinics with Walgreens, and half of those are going to be in underserved areas. So we feel like the ACO reach model matches up with what we as a company are looking to do going forward.
Yeah, thanks very much.
Makes a lot of sense. Thinking about, and we've gotten a few of these questions already from some of our panelists. From an operational perspective, right, given how many aspects there are to this program and to do well in this program, et cetera. Andrea, let's start with you. What would you say is some of the sort of the key groundwork if you had to give recommendations for those kind of just starting out in value-based care that are really key to sort of doing this right?
So I think one of the keys is you have to be able to do care coordination. And so part of that for us was ensuring we had good admit, discharge, transfer ADT feeds so that we knew what was happening to our patients when, and that we could be responding. So if they were in the hospital, we were able to reach out and say, hey, we see you're in the hospital, and we want to make sure that you're in our office within 3 days of leaving that hospital so we can coordinate your comprehensive care plan of what's going on. I think it's ensuring that you have coding accuracy, because in order to do high-risk case management, you have to make sure that you can identify who has CHF, who has COPD, who has diabetes. And so you need to make sure that your coding is accurate so that you can appropriately know which patients to outreach to. I think you have to have support staff for your physicians. Your physicians are the leaders, but you also need care managers. You potentially need community health workers, and you have to think about how you're going to support your patients, not just when they're in your office, but 365 days a year. And for us, part of that is, Maslow's hierarchy of needs. You have to think about the whole patient and not just what's happening in front of you in the office. And the one thing I would add to that is the ability to create analytics. You've got to have data on what's happening with your patients, so you know where the opportunities lie, so you know how to address those.
Yeah, no, data is huge to success in these types of programs. And from our experience with clients, it seems like, some of this can't all be handled internally. You need to have sort of the right consultants and sort of independent third parties involved. Do you find that to be the case for some of this?
I think for some it is. I think if you're new to this, you're going to have to use outside companies to either bring your data in and put it in analytics, or to develop your care network. I think you're going to need some additional support. I think for a lot of us, we've been doing this since the pioneer. So, doing this 10 years, we're now at the point where maybe we did use an external, but we've been building all of those up, that now we're happy to go full risk because we believe we've put the foundations in place that allow us to do so.
Right. So some of it just depends on the timeline of your company. Yeah. And how far along you are. Makes sense. Spencer, I know you and I have talked about this a lot in the past. Anything to add to what Andrea said?
Maybe kind of on that last point around where you are in your journey, right? Like, Village has been doing this for 10 years, right? You all very much understand what it means to be within this, not exactly this program, but other programs like it, understand what it means to do that. There are, I think, like a lot of complex administrative compliance and other things that come along with kind of participating for the first time. And I think getting that muscle of understanding what it means to kind of participate in a value-based care model and a CMMI model does take a little bit of getting used to. As we've thought about kind of our mission on a passion, a lot of that is we want to be able to work with smaller providers, right, that haven't necessarily gone through that journey, right, don't have those internal resources to do so, and how can we help them through that journey? A lot of that is how can we do data analytics and things that kind of Andrew spoke about at scale and kind of help improve that. But a lot of it is just even the administrative functions of how do you even participate, how do you do it in a compliant way, how do you make sure that you are really meeting all the guidelines of the model and meeting those goals, because it can get complex and can get a little overwhelming. until you kind of really get used to what does this really mean on a day-to-day basis. So a lot of that, I think, is really kind of somewhat of a challenge in the early days for organizations that are just stepping into it.
Yeah, absolutely. And explaining it to providers.
And
Yeah.
Christina, can I add on this? I think Spencer was so right on with that. That working within CMS is not like working with maybe a commercial or MA payer. People often, you might forget to add a physician onto the roster. They're like, well, just call CMS and ask them to add that physician on. It doesn't work that way. And so I do think having consultants who really understand how to work with CMS, I think that is one critical external support everybody needs.
Yeah, agreed. And would be curious. I know I have a perspective on this that I'll share, but how easy has it been to work with CMMI on hurdles? Does it really depend on what the hurdle is? Do you feel like there are open lines of communication? How has that gone?
Not just from this model, from the next gen MSSP before it was a permanent program, I have found CMMI to be very easy to work with. They're very responsive. It doesn't mean that they can fix everything. There are things that are greater than them from a systematic standpoint that maybe happen one time a year for the government. And if something's wrong, it just is that way. But I have found them to be very open to helping us work through our problems. And I really appreciate that they have dedicated teams that help support us.
Yeah, we have found the exact same with this model or the kidney care model or some other models that are running simultaneously. Sarah, why don't I kick it to you for the next question? I know I want to be sensitive to time. We have a lot to cover.
Yeah, sure. Before I start, Deepak, I wanted to give you, if you had I saw you came off mute, anything to add about how working with CMS is. Yeah.
Yeah, well, actually, maybe in one step back, going back to, if somebody's entering new or very early in their journey, I think I would say if you want to get into value-based care, do it for the right reason, right? So this model gives you a lot of flexibility, but it's also could be a double-edged sword, right? You could go down 10 different paths and get lost on your way. So I would encourage folks who are either new or coming in early in their journey to kind of have a clear goal in front of them and kind of map towards that goal. It seems pretty obvious, but I've seen provider groups who kind of start out trying to do many things and kind of don't do any of that well and kind of get disappointed. So I would just encourage folks to kind of be very clear in their mind where they want to go.
Yeah, that's a very good point. I'm interested in folks' perspective on the new health equity provisions of the ACO REACH program. I know that's a new focus of CMS, a general focus of CMS writ large, and we're seeing now in the ACO REACH program, one of their first forays into how they expect that to work on the ground. So Deepak, why don't we start with you in terms of how is CMD thinking about the new health equity requirements of the ACO REACH program?
Yeah, so I would sort of give a two-part answer to that. So one is just if you think about value-based care, and Andrea touched on data analytics and population analytics kind of being one of the foundational elements. And when you do that, and if you actually do break it out by race or ethnicity or kind of population, that slice of the data, it's kind of very evident that there are subsets of our communities which are really struggling from a health perspective, right? So in a way, if you think about it from that angle, health equity and the focus through this ACO REACH is very much aligned with the kind of overall value-based care and population mission we are all set out to achieve. So that's sort of one way to look at it. The other way to look at it is, and from our ConveneMD perspective, we are also a B Corp organization. We are B Corp certified with folks who might not know about it much. It basically measures you on different metrics of social impact, environmental impact, how you interact with the communities. And that's something actually we have shared some of that input into the CMS's conversation as we've given feedback that a lot of what happens in the B Corp process is quite well aligned with actually the ACO REACH mission or goals CMS is setting out to achieve. So we are hoping that they will add up some of those inputs into the process. So we are kind of in that health equity community impact space already, even before ACO REACH came about. And we are thinking that this could be a really good alignment for us because we're kind of quite far along in this space already.
Yeah, it's a good point. And I know everyone is waiting for more definitive guidance from CMS as to what that is, what their expectations are. So interesting point. Spencer, why don't we go to you next? how in the high needs community, right, there's probably these divisions are maybe even more exacerbated, and I'm curious how you all are seeing that and what you're doing to address that.
Yeah, absolutely. And I think when we've looked at some of the data, kind of echoing Deepak's observations on the kind of the differences we see across different sets of groups of patients and beneficiaries are really stark. I think one thing, even zooming farther out, is kind of on a macro basis, we've seen a lot of difference of penetration of value-based care models across different kind of groups and communities, right? And if we believe, and I think all of us do on this call, on the benefit of value-based care and the better kind of care that can provide to patients, right? That kind of stark disparity that exists between penetration of value-based care is kind of a macro problem that I think CMS is taking great steps kind of with this type of adjustment to solve, right? How do you solve what has been really historic under-penetration of these value-based models in different communities? Some of that is structural. Some of that is kind of them recognizing with this benchmark adjustment that there are some things that are not being adjusted for in different ways. But I think overall, kind of all these are coming together, have both the great potential for, within our populations that we're already caring for, to be able to kind of drive more, equitable care across different populations, but also as you think about expanding value-based care and kind of more penetration in different parts of the country or different communities that haven't had it historically, providing more of that incentive to go and do that. So I'm really excited to see what comes of that. I think this is the beginning of what will be a long journey, right? This is, the first foray into entering into this program. Now that we'll have started data collection efforts that are part of the program as a requirement, with that data, they'll be able to do more. So I think this is one where I think we'll see a lot of kind of innovation and iteration over the lifetime in the model, as both participants like ourselves and CMMI get experience with these things in the real world.
Yeah, I mean, oh, sorry, go ahead, Sarah.
I was going to say, so, I think that in value-based care, right, since the inception of these value-based care models, the Medicare Shared Savings Program and the various iterations of those accountable care organizations and other integrated delivery models, including the models of CMMI, the voluntary models, the mandatory models, I think that CMS has recognized, and in their 10-year plan, recognize that these models are not penetrating diverse communities and that there are whole swaths of our population who are not getting the benefit of the enhancements and improvements that come along with these models. So appreciate that CMS is using that as a metric and a factor in this particular model, and I'm interested to see how it works. I think that there's some thought in the community that it's a bit clunky. We haven't quite figured out the metrics and the measurements yet. And I'm curious to see what their specific guidance is, because even when you read the definition of what they consider to be health equity, it's still very lofty and ambitious. But what does that really mean? So, I'm excited to see what you all do with your organizations and how CMS builds this, and what does this look like 10 years from now, right? Anyways, Christina, and then we should give Andrea an opportunity.
Oh yeah, I was just going to say quickly, and it'll be interesting to see with this data collection, what the data shows and how, CMS will be able to plan in future models, given the data that'll be collected and trying to incentivize access to this population. Andrea, anything to add to that before we move to the next topic?
The only thing I'd add is that I hope companies look at this and take this movement forward for all of their populations, and not specifically for just the patients that are in ACO reach, but they think about how do we achieve equitable health across all the patients we care for and do not limit it to just the ACO.
Yeah, that's a very good point, Andrea. And I think that's also among CMS's goals, is by imposing requirements like this on a specific population. The hope is that it has a broader application.
Yeah, so turning to, beneficiary engagement, what are some things that you all have seen from sort of a beneficiary enhancement perspective? There are some sort of enhancements under this program that can be really helpful with respect to, reducing costs and care coordination. Andrea, why don't we start with you from a beneficiary engagement or enhancement perspective? What have sort of been the highlights for Village?
So one, I would say it's not always easy because patients have come to think that they go to see the doctors when they're sick. And so preventative medicine has been a little bit of a struggle, and it's taken years and years to educate our patients that we want to see you even when you're healthy. We want to set benchmarks and baselines as to where you are so we can see the smaller changes and not have that first, big change be when you end up in the hospital. So had to have been a lot of engagement. The waivers have, allow us to do so much more in a safe and protected way. So we know that patients won't come in for preventative screenings if the transportation is something they can't afford or don't have. So being able to use waivers and in-kind services that are protected to, maybe it's provide transportation, the cost be, Part B cost sharing has also been another great benefit. So chronic case management, which we know is important, and having that time with the patient is important. Being able to write off those copays are very important. And for us, the SNF waiver, we've not had to use this year because it's been protected under the public health epidemic. But the home health one we're currently using, which allows our physicians to authorize home health for non-homebound patients. We in the past would have patients who were not homebound yet for some reason they were either scared to go out, maybe they couldn't go out, and being able to authorize that preventative care that the doctor thinks is important or rehabilitative care has really been a benefit for us.
Yeah, the home visit benefit enhancement is huge. And just so the audience knows, some of these enhancements you have to apply for is too strong a word, but you do have to let CMS know that you do want to participate in the cost share and your plan for doing so. And there is sort of requirements to meet these enhancements, and those are typically in the appendices to either the participation agreement or for REACH, it's the RFA. Where it sort of outlines what the requirements are. Andrea, how have you found for the DCE program complying with those requirements has been? There's quite a few requirements, and I know that sometimes they are audited for. And do you have anything to speak to that?
So I won't say they're audited for, maybe every one of them is audited. If you do it, it's audited. You should know that. You should be prepared for that. And it does take a long time to ensure you have everything in place. But I think what thing that CMMI has done is they've laid out the expectations of what is in that application very well. So it's very easy to write what you have to do. I encourage you to use your EMR or your case management system to monitor, track, and ensure compliance with all of those waivers. That way, one of the things we did was we built our waivers into our care management system. So it literally walks that case manager through every step where they have to check and validate that everything is in place in order to use that waiver. And so I feel confident as we go into audits, which I know will happen. But I really would encourage people to reference what CMMI has released, because they really do lay it out very well, and to track everything because it will be audited.
Yeah, absolutely. In me and Sarah's experience with some of our DCE clients, I will say that, audit can be a scary word, but I would say in this program, I think the audits are more of a chance for CMMI to see how folks are faring and if they do understand the requirements, as opposed to using it for a slap of the wrist or anything like that. It seems like it's been more of a conversation and more of a way for CMMI to check that people understand what the requirements are, given that there are a lot of requirements. And so I think that the audits are really done in good faith in that way.
Yeah. The other thing I'd recommend is I have found it helpful to make a champion. So for each waiver, there is a champion in the market who is the expert on it. And they've watched, all the learning system education on it. They've read everything, and they're kind of that expert, and they're the one person who checks off. And every time a waiver is used, they're kind of saying, yep, used correctly. So I think having a champion makes a difference.
Yeah, go ahead, Sarah.
Yeah, well, I was going to say, and with the audits, Christina, to your point that these are not intended to be punitive, but I do think that this administration in particular is focused on program integrity and transparency. And so they're using these audits to make sure, Andrea, to your point, that the elements of the enhancements are all being met, and that they have transparency into what you're doing. Because I think one of the criticisms of the DCE program back last year before it was changed into the ACO REACH program is that there isn't a lot of transparency into the program, and there's so much flexibility that participants could really do anything they want. And I think this administration is struggling with, how do we monitor that? How do we make sure what's being done advances the program goals and doesn't create these mini markets for something that, just spins out of control that we can't get our arms around. So I think these audits are just one tool in how they're doing that.
Yeah, I agree. And I think that, for people that are going to be new to the ACO REACH program for whatever reason, if they weren't able to get in on DCE, to state the obvious, having a member of the team listen in on any CMMI office hours or webinars, et cetera, because I do find that those are hugely helpful to sort of tease out what CMMI is expecting with respect to some of these requirements, and it's an opportunity to ask questions. Should we turn to voluntary alignment? I know that that's sort of a key topic. Spencer, with respect to the high needs, voluntary alignment works a little bit different. There are more requirements. Do you want to speak to that?
Yeah, so I think for high needs, and I talked about a bit about it earlier, but there are really kind of two challenges that we've seen for voluntary alignment for high needs specifically. We're really excited about it as a mechanism to get patients who are kind of coming on panel and needing this level of home-based care during the year, right, and not having to wait till the next cycle, which might be the next cycle because of lags in claims-based alignment, to get them into a value-based construct. But two of the challenges exist. One is around that eligibility criteria that I mentioned earlier, right? Knowing and predicting whether a patient is meeting a 3.0 risk score, right, at any given moment at a time, or a 2.0 with hospital admissions, or kind of these things that take a little bit of data that we might not have to turn and predict, right? When you get this voluntary alignment signed, if you do get it signed, whether or not they're going to be eligible for high needs or not at that moment in time can be a challenge, right? And can be confusing for a patient, right? If you are saying, here's this model that has a lot of benefits, you may or may not be eligible, we'll find out later, is a tough kind of message to be able to drive. So I think that eligibility criteria, particularly on voluntary alignment, can be a little bit of a challenge. I think coming back to the data perspective, there are things you can do through some of the CMS APIs to get more historical data to get better at kind of predicting. But that's one of the challenges, particularly around high needs for voluntary alignment. And then one more from a compliance perspective is that doing voluntary alignment within patients' homes, there are kind of additional restrictions that exist on kind of providers or others, or in having that voluntary alignment conversation with a patient in the home. So that has kind of operational challenge that come with it, given that these are home-based providers, right? And these are home-based patients. That is the kind of setting that they're interacting in. And these additional kind of restrictions are sometimes harder to navigate and understand to be able to try to have those conversations with patients and do it in a compliant way.
Yeah, Spencer, I've heard that from a multiple of my high needs DCE clients. I'm curious if you're aware of whether CMMI is thinking about addressing that, particularly in the high needs context when they come out with the ACO REACH agreement.
Yeah, I think similar to your other clients, I think many of us have expressed this to CMS in one of the areas that's a challenge. I think there are concerns, right, as you don't want to be putting patients in a position in which they feel like they can't say no, or there's so it's all for good reasons. I think it's all balancing, right? Balancing, how do we balance the risks and the potential rewards that come with being able to provide these patients more benefits. So I hope to hear, but we will see.
And Deepak, I know that voluntary alignment is one of Convenient MD's primary modes of engaging beneficiaries. So before we move off this topic, I want to give you an opportunity to weigh in.
Sure. Really quick. So you're right in terms of that's our sort of main mode of acquisition, given we are very early in our life cycle. But I would say that just in general, the process CMS has set up for a new primary care clinic is relatively straightforward. So I think it's a very straightforward process. A lot of credit to CMS, very simple forms. And CMS has also been very responsive, going back to one of the themes we talked about earlier, when we have gone to them and said, like, hey, we want to try this approach versus that approach, as we have been testing different recruiting approaches out in the marketplace. I think very receptive, very open, and maybe some feedback or tweaks from their side, but quick responses and gives us an ability to kind of get out there and keep the ball moving forward. So overall, I would say it's been a good experience for us on the voluntary alignment side.
Yeah, great. Thank you for that. I would just remind panelists, if you do have any questions, please do put them in the chat. We'll wrap up with a couple more questions here and happy to answer any questions that you all have. And if not, we'll allow folks to go early. I'm curious, because here we are, the law firm hosting this panel. When do you call your lawyers? What kinds of issues have you confronted with the DCE program or that you're anticipating with the ACO REACH program when you feel like I really need to talk to my lawyers about this? This is complicated and confusing.
And before you answer, I'm going to say the CLE code so that we don't forget. The CLE code for this program is 6981.
And we'll put that in the chat as well. Andrea, I saw you smile there. Why don't you start us off with this one?
I smile because I feel like I call my representative all the time. You know what? For me, it's a nice safety net, and so anytime I'm responding to an audit, which again I feel like CMS is trained to be fair with those. I almost always run everything through our legal department, just so they're through the lawyers, so they're looking at it. I also have found that, specifically, I work well with a lawyer at your firm, and when we're questioning, we're finding an issue with the way the model is set up. And we feel like there's methodology that has an intention that, maybe it's not going to happen the way CMS was intended, or we feel like it's having consequences that shouldn't be there. Being able to work with them to say, how do we approach CMMI and say that maybe it should look like this, or we'd like you to consider this. I have found having a lawyer is very helpful to write that in a way, because often it's CMS's lawyers who have to respond to those things. And so going lawyer to lawyer has been easier, as well as CMS is late to give out guidance. So nobody has an ACO REACH agreement right now. We're not going to get those till December, yet everything is supposed to be in the contract that's signed by September 4th. And so being able to reach out to your lawyer saying, based on the knowledge of what you have over the past 10 years, what should I be doing, since they're not going to tell me till 6 months after it's due? And so I find you guys very helpful when I think about what do I need to be doing that CMS hasn't released yet.
Yeah, right. We have to tell the participant providers what the terms are that they'll be bound to by August 4th, and they have to sign agreements. But CMS hasn't told us if they're going to impose any additional restrictions on that. So yeah, I hear you. We are frequently asked to be fortune tellers. Deepak, did you want to respond next?
Sure. I mean, I'll say we haven't started our operations yet, so I haven't had an opportunity to kind of run into many of the issues Andrea is referencing. So not a lot of phone calls to our lawyers yet, but I do anticipate, as we start actually operating. And I think especially on the compliance side, that's one area for us. I've been working with our internal compliance team. On the urgent care side, we have our ducks in a row, and we are trying to figure out what our strategy should be on the primary care side. So I do anticipate that's an area where I'll be reaching out, Sarah, to you or others on our team to kind of help figure that out. So I think compliance is an area which I do anticipate making some phone calls we haven't made yet, but I think they're coming soon.
Sure. And Spencer?
So I feel like the main areas that I've reached out to both of you have been, there's a lot of gray areas within these models, right? There's a lot of interpretation, right? There's things, and having written some of this myself, I am there's a lot of details that need to be figured out later, right? And some of these is like, as we talked about, requirements, but also there's a big difference between kind of setting a policy and implementation. And I think that there is a lot of times where like that evolves, right? And I think those in the early times kind of feel like gray areas, and having kind of legal counsel to help think through those gray areas and what they can mean when a policy translates to implementation. Right? What does it mean to take this few sentences and make it an actual policy is a great area to get feedback on, to kind of give some of that confidence to then kind of operate against.
Yeah, that makes a lot of sense. I think it's also, helpful from an industry benchmarking standpoint. If a firm like Ropes has multiple not only DCE clients, but clients in other CMMI models, to see sort of, what we're seeing at a high level work or not work.
Yeah, and I think we have used our experience of various models to build what our expectations are, coming into some of these other models. We are starting to run out of time, so I want to thank our panelists for participation. This was really interesting for me. I hope folks here enjoyed the conversation. There's a lot more in ROPE's Value-Based Care 2.0, what lies ahead. So invite the rest of you to tune into other panel discussions if you haven't already. There's a link in the chat to the other options, so you can see the other panels that are going on for the rest of the day. Christina gave the CLE code. I'll give it one last time in case you missed it. It's 6981. That should be in the chat as well. And thank you all for joining, and enjoy the rest of your day.